Good evening, everyone, and a warm welcome to our esteemed panelists and participants. I am Dr. Falgun Vyas, moderator for today's expert panel webinar. I am General Manager in Medical Affairs with Bharat Serum and Vaccines Limited. I am an MD Pharmacology with MBA and MSc in Biotechnology with over 16 years of work experience. And it is my pleasure to open today's expert discussion on a topic that continues to challenge emergency medicine across India, snakebite and venoming, a year-round medical emergency. So, India is regarded as the snakebite capital of the world, contributing to nearly 50% of global snakebite fatalities, with an estimated 58,000 deaths occurring annually. While 3 to 4 million bites may occur, most fatal incidents happen in rural areas. Most public attention peaks during the monsoon, the reality is very different. As documented across multiple epidemiological studies and regional case reports, snakebite envenoming remains a persistent year-round medical emergency that does not wait for the seasonal patterns to unfold. So, why beyond monsoons? The title of today's webinar captures our central message that there is no off season for snake bites. Throughout the country, clinicians consistently manage serious cases during harvest cycles, winter irrigation, and other non monsoon activity peaks. Many of most complex or delayed presentations actually occur outside monsoon months, but system level preparedness often declines during this period. Bharat Serum and Vaccines Limited has always been at the forefront of raising awareness about snakebite treatment through impactful initiative previously also such as सांप का वार अस्पताल में उपचार, consistently educating the public on importance of immediate hospital care, helping reduce preventable complications and fatalities. So purpose of today's session is to reinforce that preparedness for snake bite must remain strong throughout the year, not just during the monsoon alert. So today's webinar include launch of snake bite training modules, drawing practical learning from real world non-monsoon case experiences, ensuring year-round stocking of sufficient quantities of anti-snake venom, improving patient access pathways to snakebite treatment centers, and introducing a new strength of anti-snake venom. So, this expert panel includes some of the most distinguished and knowledgeable specialists in snakebite care. We are privileged to have with us seven senior emergency physicians and government officials from all four zones of India. So I will introduce the panel and I'd like to start with Dr. Omesh Kumar Bharti from North Zone. We are honored to welcome Dr. Omesh Kumar Bharti, Padma Shri awardee and one of India's most influential public health physicians. He pioneered India's first low-cost intradermal anti-rabies clinic and developed the globally adopted wound-only rig infiltration technique. His work shaped India's national snakebite management guidelines, and his research is cited in WHO snakebite guidelines. With decades of field leadership, Dr. Bharti remains a leading advocate for low-cost, high-impact public health innovations. Welcome, Dr. Bharti. Our next panelist, Dr. Sadanand Raut from West Zone. He is India's leading snakebite toxicologist, consultant physician, and cardiologist, and a WHO roster expert for snakebite envenoming. He is the director of Vighnahar Nursing Home. He has served rural Maharashtra for 35 plus years and leads Mission Zero Snakebite Death, saving over 12,000 lives with 0% mortality and morbidity. He heads one of India's most active snakebite treatment and training centers and offers 24/7 free guidance massive public awareness and doctor training, and is widely honored, including with Baba Saheb Thackeray Arogya Ratna Award by Government of Maharashtra. We welcome Dr. Sadanand Raut. Our next panelist, Professor Dr. N. Ganpati. He is a senior critical care physician, anesthesiologist, and toxicology expert with over 40 years of leadership. He is the director of Dhanvantari Critical Care Center since 1986. He has trained 2,000 plus doctors in trauma care and served as national director for major trauma programs in India and abroad. An internationally recognized faculty, he has deep expertise in snakebite toxicology, OP poisoning, and advanced ventilatory strategies, shaping emergency care standards nationwide. We welcome Dr. N. Ganpati. Our next panelist is Dr. Dayal Bandhu Majumdar from East. He is a senior clinician and a national snakebite expert with over 3 decades of service. He has been a state resource person for snakebite training in West Bengal since 2012 and served on National Snakebite Treatment Guideline Task Force under Ministry of Health. A technical advisor to ICMR, Dr. Majumdar brings outstanding field experience in training, protocol development, and strengthening public health system for snakebite mitigation. We welcome Dr. Majumdar. Dr. S. Senthil Kumaran from South. He is an eminent emergency and critical care physician and a board certified clinical toxicologist. He is the medical director of Manian Medical Center and prolific researcher with over 330 PubMed indexed publications. His landmark contribution on snakebite-induced acute kidney injury, neuroparalysis, and venom-associated thrombotic complications have significantly shaped management protocols. He has served on WHO snakebite guideline committees, advisory panels of NCDC, and multiple toxicology bodies across Asia-Oceania region. Recipient of more than 40 prestigious awards, including the Indian Society of Toxicology Distinguished Service Award, he stands as a driving force in advancing toxicology, research, and emergency care in India. We welcome Dr. Senthil Kumaran. Our next expert, Dr. Uttam Ingole from West. He is a senior anesthesiologist and a snakebite management specialist with extensive experience across government medical colleges and rural hospitals in Maharashtra. He is strong expertise in managing critical emergencies like snakebite, poisoning, and ventilatory failures. Dr. Ingole has presented influential work at national conferences, especially on ventilatory support in neuroparalytic snakebite and OP poisoning. And he has led multiple public awareness programs on emergency medicine and toxicology. We welcome Dr. Uttam Ingole. Our next panelist is Dr. Joy Kumar Chakma from North. Dr. Joy Kumar Chakma is a distinguished public health specialist, epidemiologist, and scientist F at ICMR, where he heads the central procurement cell as well. With 25 years of experience, he has 52 publications with over 5,700 citations. Dr. Chakma led the landmark ICMR white paper on e-cigarettes, shaping India's 2019 national ban. And he serves as nodal scientist for the ICMR National Task Force on Snakebite. He is recipient of several prestigious recognitions, including ICMR Research Excellence Award. Our next panelist is Dr. Krupa Murzello. She is as Assistant Vice President and Head, Research and Development with Bharat Serum and Vaccines Limited. She is having extensive expertise in biological research and innovation. Dr. Murzello will share key insights on advancing scientific solutions, strengthening antivenom development, and supporting improved patient outcomes in snakebite management. We welcome Dr. Krupa Murzello. With that introduction of the panelist, I will move to the next section of introduction and launch of the snakebite training modules. Bharat Serum and Vaccines Limited, in consultation with snakebite treating experts, prepared 6 comprehensive training modules. These training modules will play a crucial role in strengthening clinical care training in future. I would like to show you a video relating to these training modules. Collectively, these training modules are more than training. They are comprehensive strategy to empower healthcare providers in reducing mortality and preventing long-term disability at every level. With that introduction of the training modules, I will ask our panelist, Dr. Omesh Kumar Bharti, who has been instrumental in preparation of the first module, to provide his feedback. Dr. Omesh Kumar Bharti.
Yeah, thank you. Can you hear me?
Yeah, you are audible, sir.
So first of all, I must congratulate BSV, BOH, and Mankind for this innovative idea of launching this online module for the doctors, especially those in the rural areas who don't have access to the modern trainings and modern tools. So my heartiest congratulations to all the stakeholders and the trainers who dedicated their time and energy to prepare such a wonderful module. So apart saying that, I would say that these modules are going to be very useful, because in one of the I launched this module in one of the trainings where the BMOs were there sitting in front of me. It was a snake bite session, and some doctors were sitting. And when I read the module and recorded this module, I think they were very happy to know that this epidemiology of the snake bite was really benefiting those doctors. So, taking a cue from that, I think this module is going to be very helpful. And I'm really thankful to all the stakeholders. Thank you, and best of the wishes.
Thank you, Dr. Bharti, for your apt feedback and your support in preparation of these modules. I will request Dr. Sadanand Raut, who was also involved in module preparation, to provide his feedback on training modules.
First of all, I must congratulate uh, Bharat Serums and Mankind and VOH for preparing this very informative and comprehensive roadmap for the doctors working in the rural area. And all the models, they are very informative and will be useful for the doctors. Module 1 tells us why the problem is very large. It tells severity of the magnitude. Module 2 teaches about the early recognition of the red flags, such as drooping of the eyelids, then neurotoxicity, signs of hematotoxicity, etc., and proper diagnosis. Module 3 guides us regarding the immediate treatment, the importance of immediate treatment, how time is very important. Module 4 about the builds system readiness, how hospitals should be ready to treat each and every emergency of the snake bite. Module 5, of course, standardizes the hospital care, and module 6 prepares us for critical complications. So all these models together transform fear into the confidence and confusion into the clarity and delay into the decisive action. Snake bite is a preventable. Death from snake bite is also preventable. So with this knowledge, preparedness, and timely intervention, we can save thousands of lives. That's all. Congratulations once again. Thank you very much.
Thank you, Dr. Raut, for your valuable inputs and your support in preparation of these modules. Soon we will avail these modules for training of healthcare providers. Uh, with those insights, we are moving to our next section of non-monsoon snakebite case discussion. So, basic objective of webinar is to reinforce the message that snakebite envenoming is a continuous year-round medical emergency, thereby strengthening preparedness and response across healthcare facilities is required all year round. So each panelist will share within 5 minutes a quick real case snapshot, why it occurred in non-monsoon period, and clinical relevance and key learnings. So I will like to start with Dr. Dayal Bandhu Majumdar, who has also support us in preparation of one of the modules, but we'll take his inputs relating to this non-monsoon case highlight. Dr. Majumdar, over to you.
Good evening, everybody. We have a very big WhatsApp group for discussion of snakebite cases throughout the year. All my cases which I am going to show you, they will be from the WhatsApp group only, which we have collected from our WhatsApp group. Actually, snakebite occurs throughout the year. There was a myth that snakebite does not occur in the winters. Let me show you. This is a refer card from a rural hospital of West Bengal. I have got it just last night. 11-year boy came to this rural hospital with an unknown bite. He was kept under observation for the next 15 hours, then got discharged. Again, the boy came to the hospital at 9:10 p.m. just last night with pain abdomen, nausea, shortness of breath, and 20 WBCT was not clotted. So it was diagnosed as a case of Russell's viper bite and was accordingly managed accordingly. Russell's viper bite occurred on 15th February 26. 15th February. See, it's winter now in West Bengal. Till now, here we are in winter season. Next, you see, very interesting case. It was a case published in a local newspaper, Bengali newspaper. It is written in Bengali over it. The bite was on 14th February, last Saturday. It was a Russell's viper bite. A groom was going to marry by cars. They dropped by the highway for nature's call. There he was bitten on the foot. He was treated at Mangalkot BPHC, Block Primary Health Center only. It was a case of Russell's viper bite, again diagnosed by 20 WBCT. The most interesting thing is they had attended the nearest BPHC only. BPHC in some areas they are called community health centers, CHCs. The smallest bedded health unit in West Bengal are called BPHC. In West Bengal, all the BPHCs are equipped for managing snakebite cases. They didn't run to the Bardwan Medical College 35 kilometers away. They entered the Mangalkot BPHC and he was managed there only. After infusion of antivenom and observation for 3 hours, patient party requested the doctor to release the patient, that is the groom, to go to the marriage ceremony. He went to marry the new bride, again came back to the health center and admitted. He was referred to a higher center as it was a case of Russell's viper bite. They were suspecting renal injury, but there was no kidney complication and the patient was discharged from Bardwan Medical College. You see, this is a very old case from our WhatsApp group. It was on 20th November 2015. Our big WhatsApp group includes all the snakebite experts of India, including Dr. Omesh, Bharti and Sadanand, Raut, Dr. Babaskar, Dr. Dilip Punde, everyone. And also experts from Bangladesh, Dr. Professor M.A. Faiz, expert from Nepal, Professor Sanjeev Sharma, all are there. We discuss every day plenty of cases, particularly in the summer and rainy seasons. And this case was of 20th November, that is early winter. It was also a Russell's viper bite and treated by Dr. Subhendu Bagh at Debra Rural Hospital of West Bengal. It was very interesting, and I used to show this case in all my training programs. You see, this lady was bitten here on the lateral aspect of right foot. She ran to her home to go to the hospital quickly and had an injury on the second toe of left finger, left toe, in the second toe of left foot. When Dr. Bagh got this patient just 20 minutes after the bite, there was continuous oozing from the second toe of left foot. That only led Dr. Bagh to diagnose it to be a case of Russell's viper bite. He immediately started antivenom. Then he took blood for 20 WBCT. 20 WBCT obviously became not clotted. She was cured at Debra Rural Hospital in 2015. She was not referred anywhere. She had some swelling of right foot for 5 to 7 days. Dr. Bagh managed it beautifully. See, another case, it was from Assam. It was treated by Dr. Surajit Giri. It was a case of cobra bite. Cobra bite on 25th October. You see, it's 25th October, that is non-monsoon period. Just 25th October 25, Dr. Giri treated this case of cobra bite. He had slapping up some tissue from the dorsum of the left foot. Dr. Giri managed it by skin grafting. Now this patient is almost cured. I am adding just 2-3 sentences for preparedness. Don't think that only antivenom will cure all of your patients. This is a very, very bad myth that I have plenty of antivenom, so I am prepared. Always keep atropine and neostigmine in stock. Always keep atropine and neostigmine. All these unfortunate patients died even after getting 20 vials of antivenom. This Jaydev Mandal, he was a science worker. He died after getting 20 vials of antivenom as there was no neostigmine in that health center. This 26-year lady died after infusion of 18 vials of antivenom because there was no neostigmine available in that center. So always keep atropine, neostigmine and adrenaline along with antivenom. Thank you. All these are my cases.
Thank you, Dr. Majumdar, for sharing the insightful and interesting cases. I would like to call Dr. Ganpati to share his bite relating to the non-monsoon cases. Dr. Ganpati.
See, each case present with their specific signs and symptoms belonging to the species. One advantage between monsoon and non-monsoon snakebite include witness, because in non-monsoon period, most often they bring the snakes either dead or alive with them. So it will be easy to diagnose and treat. Furthermore, transport facilities are better in the non-monsoon period for shifting a case or for shifting a patient for neuroimaging or ease for traveling to blood banks. Eventually, there is no specific cases that alter its presentation depending on the season in our entire center. Can I share the slide, please?
Yeah, sure, sir.
So I have to go in for share screen.
Yeah, you can go to share screen and your
Allow
screen
share
will
screen.
be visible. Yeah.
Now here I get full to exit. share entire screen. I'm not able to get it.
Yeah, please allow share screen for Dr. Ganpati.
Sure.
Yeah, you can start with
I'll just see.
yeah.
So
Not
here
yet.
I say,
No,
I'm not
we are
able
not
to.
able to see your screen, sir. You need to
Yeah.
open that window.
No, which window?
The presentation window. If you open the presentation, then it will be visible. This is the webinar panel open.
Okay. No, I just
So if
want
you
to show a movie.
yeah. So if you go to the presentation, if you start the presentation, then it will show.
No, here below, what am I supposed to do? I am going in for plus. Stop screen, it is there. Share screen, I have gone in for share screen. Then shall I open the share screen now?
I think, have you logged in from 2 different devices?
No. Only one
Okay.
device I have logged in. Just a minute.
Yeah. So can you share your screen again?
Yeah, I'll just see. I have gone out and I'll come in again.
Yeah.
It is loading.
Okay.
The studio is full. Try again. So I have logged out and I am connected because one movie I want to show. If it comes, it will be good. I'll see. This.
Okay.
Try again. Loading.
Otherwise, you can narrate the experience if possible. I think by then we can, till Dr. Ganpati starts his case, we can start with Dr. Senthil Kumaran.
Dr. Ganpati,
Yeah, Dr. Ganpati.
there is having one option while like there is having one option plus
Plus.
and
Yeah.
there is one option video file. If you wanted to
Yeah.
share any video file, then click on video file and choose your video file. From there, that video start playing.
Okay, video file, it will come in my video file I have opened. Okay, done.
No, sir. Like just there is having one option camera. Beside camera,
Yeah.
there is option having plus. So first, just click on plus, and then there are having different options. So in that, there is one option video file.
Yeah.
So click
I can go in now.
Then click on video file.
Yeah, upload.
And now,
Is it audible? No.
wait, sir. Sir, yeah.
Yeah. Yeah. Is it audible now?
Yeah, audible.
Hello. Snake charmer. So in monsoon or non-monsoon, one of the cause of snake bite is by snake charmer. He was a snake charmer who was showing in a show, and when he kept the cobra in his mouth, it bit him. he became very serious. And he was brought to our hospital, which is a tertiary care for snake bite. And all the other figures I have not shown. He had a swollen tongue. Immediately we intubated him. Then he was there on the ventilator for 5 to 6 days. Then we did plastic surgery and he became normal. So just I wanted to know, even in snake charmers we get easily in monsoon and non-monsoon, we get easily 5 to 10 snake bite cases. As is a tertiary center, apart from anti-snake venom, we go in for plasmapheresis, hemoperfusion and everything. Thank you.
Thank you, Dr. Ganpati, for sharing insights relating to no difference between the monsoon and non-monsoon case numbers at your center. I would like to welcome Dr. S. Senthil Kumaran to present his case. Dr. Senthil Kumaran, can you please present your case? Yeah.
Just
Yes.
upload it. It's coming. Just 2 minutes. It's just processing.
Yeah, sure.
So we are talking about non-monsoon. We are talking about more on ASV. Beyond ASV, we are seeing lot. I'm just showing. Most of the time, this is a case of snake bite where the ASV was given. The monsoon, it was a non-monsoon bite. The patient presented with a dilated pupil. As Ganapati sir told, we need a tertiary care backup. So this patient was selectively ventilated and then the patient improved well. And this was a case, surprisingly, this is a daughter of a superintendent of police who had an abdominal pain in the early morning, had a vomiting, then taken to a prison medical officer, examined and considered as this a case of acute appendicitis, sent to a local hospital where appendectomy was done under spinal anesthesia. Surprisingly, this patient subsequently this patient developed difficulty in breathing, and then patient went for respiratory arrest, shifted to our hospital for further ventilatory support, then turned to be as a case of crate bite. So 2 crate was there in their home. This was also in the non-monsoon time. So this is nothing but ptosis. They thought it was an high spinal and unnecessarily the anesthetist was caught. So early morning, acute morning, they come with the abdominal pain, vomiting. Even the younger children comes to our hospital. Then it turned to be a snake bite. Once you give ASV, they improve very well. You can see the dramatic improvement within half an hour of 10 vials of ASV. The patient improved very well. We also see this kind of patients like a painless envenomation. They were absolutely normal, going for a bed. In the early morning, they are waking up with that. They'll be found standstill. Okay, most of the time this is considered to be a vascular event. CT, MRI done. Even one patient was thrombolized with newer antithrombolytic, and then the patient didn't improve, developed respiratory depression, sent to our hospital, then turned to be a snake bite. It's a painless envenomation. So we have witnessed in the non-monsoon time, we see a lot of patients with convulsions, unconsciousness, hypertension presenting as symptoms, but turn to be due to the either cobra bite or crate bite. So this patient, you can see this patient developed facial puffiness, capillary leak, everything with the Russell Viper. Again, this is in the non-monsoon period. So swelling, everything, sudden there will be a increase in the swelling. You can see they will go for a glaucoma, open and closure angle glaucoma. Multiple swelling can be there. Even CT abdomen, you can see there is an adrenal bleed. These kind of most of the patients we see during the non-monsoon time. There's also one of the case we published in Wilderness Medicine about Addisonian crisis following a Russell Viper. So, very important thing I want to tell to the doctors, especially in the rural doctors, now they are all using point of care for measuring a PTI ANR in a snakebite case. So, this is not being reliable. We have done even scooping analysis now, and we found that this is not working. So, if you are doing a PTI ANR in a point of care test, please stop. This is a father of a doctor and father-in-law of a cardiothoracic surgeon. So they did a point of care test in their hospital, and they found PTINR was normal, but still the patient was having bleeding, oozing, everything was there. So initially it was thought it is because of fall following a snake bite, but later turned to be increased in INR, reversed with the PT and APT. So ASV reversed this. So we need to be very caution when you are measuring this, because it gives a value of up to 5. Okay, and most of the time this case is referred as an acute abdominal pain. Mostly we treat with ASV. After that we want to follow that this patient had a bleed in the perinephric space, and this is a Undrich syndrome. Then we did a CT. We found there was a gross hematoma, and the surgeons were hesitant to test the patient. So we did a angiography, embolization. We found there was a bleed in this patient. This patient was 26-year-old, doesn't have any comorbidities, only history of snakebite, Russell Viper. Then he was thrombolized, and embolization was done, and then he improved. So the reason was lack of awareness occurs in the monsoon period, non-monsoon period. They think that the snake bite occurs only in the monsoon period, so they delay in the treatment, and we need to be always anticipate. Otherwise, we will fail to treat the patient. Thank you.
Thank you, Dr. Senthil Kumaran, for sharing the variable and atypical presentation of cases and how they are reversed with appropriate treatment. I would like to ask Dr. Uttam Ingole to share his bite over the non-monsoon cases. Dr. Uttam Ingole, your mic is on mute. Yeah, now.
Yes, now.
Yeah, you are audible now, sir.
Good evening, everybody.
Good evening.
Now,
Sir, you are not audible. Maybe some network issues are there.
now you can hear me?
Yeah, we can hear you. Please.
Yes, yes. Now, today, Bharat Serum and Vaccine, they have taken initiative for the awareness of this snake bite cases, and the topic that is given is a non-monsoon period. How many and how the snake bite cases occurs. The previous speakers, they have been told regarding the snake bites and shown the slides also. I want to show you the data of 1 year. As I am practicing in this rural area, the victims are the farmers, farm workers, laborers, and those who lives in kacha houses. And to treat this emergency of snake bite, the only thing is that the patient should come to the proper hospital and proper diagnosis, and treatment is anti-snake venom only. This is a data of 1 year, that is last year. What the data it shows is that there are, if you consider the monsoon period, it is generally June, but as monsoon comes late, we consider it as a July, August, September, and October as a 4 months. When the rainy season starts, the burrows are closed and snakes they comes on the ground, and at the same time the farmers and farm workers they come to the rural area for working in the fields. And for that period there were almost 49 patients of monsoon period in the 4 months, and the non-monsoon period it is from October, November, December to June. For 8 months there were 17 patients. It means that if you come across to the percentage of this monsoon period and non-monsoon period, the non-monsoon period it was almost 25.75, and in monsoon period it is 74%. It means that definitely in monsoon period there are number of more snake bites, but in this 8 months or non-monsoon period there are also snake bite cases that are around 25%. It means that we should have to be prepared for the non-monsoon period also. That emergency came from all the snake bites. The maximum numbers in non-monsoon also they are vipers and occasionally crates and cobra bites, which were shown in the previous slides. It means that the data of 1 year cases, it clearly shows that there are number of cases, almost 25%. And these patients, generally when the patients, they are also not prepared in non-monsoon period. That's why this patient came lately to the hospitals. And as the patient, they came late, the treatment also start lately. As treatment start lately, there are more complications. That's why the first principle is that the patient, he should come early to the hospital, to the proper hospital and proper treatment. And as you know, we know that the only treatment for every poisonous for snake bites, the only treatment is the anti-snake venom. That is, if we start anti-snake venom in within time, all the complications that can be stopped. The even though that patient of crate bite, if it is generally it is very difficult to diagnose in early time. It generally these cases came 4 hours or 6 hours or early in the morning. But if these cases of crate bite, when they comes within 1 hour or 2 hour period, at that time if anti-snake venom is started, then there is no need of ventilator also. Even in cobra bite, when the patient they comes early, that is within half an hour, and you starts anti-snake venom, generally this patient also never need a ventilatory support. It means that the role of this anti-snake venom in neuroparalytic snake bite and also in vasculotoxic snake bites, both there is prime importance is start the treatment of anti-snake venom in early time. Hence, this is the data what I am showing of 1 year. It shows clearly that in non-monsoon period, the doctors who are treating this patient, they should be prepared for this emergencies, and patients they get benefit if treatment is started early. Thank you.
Thank you, Dr. Ingole, for presenting the real data at your hospital and proving the point that system level preparedness throughout the year is required to treat the snakebite cases. Next, I would like to welcome Dr. Raut to share his cases of non-monsoon snake bites. Dr. Raut. Sir, your mic is on mute, so please unmute your mic. Dr. Raut, uh, yeah, your slides are there.
Hello,
Uh, Dr. Raut,
can you hear me?
yeah, now we can hear you. Yeah,
Yeah, please go to the next slide.
next.
Hello. We have discussed
Yeah,
epidemiology and incidence in detail. We'll go to the next slide. There are
next slide.
many, like more than 60,000 days. So this is the case we are treating just now. The patient had a result swiper bite on 22nd of January, and his legs is stepped on the snake. So he was brought within 1 hour. Still, he was very critical and in severe pain and agony. Bite to needle time is only 30 minutes, but still his peripheries are cold, pulse is feeble, BPD is 80 systolic, and saturation is also 80. There is active bleeding. You can see in the pictures from both the fang mask. I thought that it is a bite is in the vein directly. So patient had a hematuria also, followed immediately oliguria and anuria almost for 17 days. His WBC is incomplete for 65 minutes. HB is 14.40 at the time of admission, which dropped slowly to 7 grams. Platelet count at the time of admission is 10,000 within half an hour after the bite. We had given ASV 60 vials, manage his shock, antibiotics were given, noradrenaline injection is given. On day 2, there is anuria, so central line is put, urea is increased, creatinine is 4.6. On day 4, he was dyspneic, drowsy, saturation is again dropped. So we have to keep on him on the non-invasive ventilator, and we have done his hemodialysis on day 3rd. So his fibrinogen level are also decreased, platelet count decreased up to 6,000. On day 10, again he had a hematuria. So there is a relapse of coagulopathy, and again we have repeated 10 vials of anti-snake venom. On day 12, we suspected APLA syndrome, that is anti-phospholipids antibody syndrome. We have investigated for that, but they were negative. Then, please take next slide.
Next slide.
Please take next slide.
Yeah.
On day 14, again there is a hematuria, oliguria continued. We have given supportive treatment only this time. Anti-phospholipid antibodies were negative. USG, there is no bleeding, there is no intraabdominal bleeding. On day 19th, there is a severe necrosis and debridement is done under local anesthesia. Day 24, there is facial and leg edema due to severe hypoproteinemia. Albumin is only 2.12. And now on today's day 26, patient is stable with normotensive, saturation is 96, and his urine output is also increasing. So this patient had all complications like severe coagulopathy, thrombocytopenia, acute kidney injury, bilateral pneumonitis, and severe anemia and this hypoproteinemia. We have to give on him almost 12 points of fresh frozen plasma, 2 bloods, and 12 dialysis till date. So this is last 2 years data of April 24 to March 25. We have treated almost 188 patients of the snake bite, and you can see in the off monsoon period from October to November, there are. You take the next slide, please.
Yeah.
Please, next slide. Next slide. Next slide. Now this is the slide. You can see that there are off monsoon 41% of the patients out of total 188. There are many patients who came in the off season period, and we have observed that off monsoon period patients, they are more critical. We are seeing patients of cobra, around 13 patients of the cobra in off-season period, 68 patients of Russell's viper, green pit viper 12, and some are unknown, and saw-scaled viper 3 also. So throughout the year in our region, there are patients. We are getting patients throughout the year, and though there are some more cases in the monsoon period. Next slide, please. Next slide. No, one before. Hello.
Yeah. Previous
This
one.
is this is
Previous to this.
this is 25, 26. We have treated till date around 224 cases of the snake bite. Out of that, 28% patient are of monsoon period. And since last month, we have treated many patients of the venomous snake bite of all cobra, Russell's viper, crate, and green pit viper. So this is the situation in our area. You can clearly see on the chart of monsoon and monsoon differences. You can see there is more rise in the June, July, August, September, but still there are a good number of cases in October, November, and December also, and in April also. So this is the statistics in our area. And more worried point is that we are getting more critical patients in non-monsoon period, of monsoon period. Thank you very much.
Uh, Thank you, Dr. Raut, for sharing the complex cases and proving the point that almost 40% or some amount of 40 around 40% cases can occur during non-monsoon period, and they can be more critical during this time. So I thank all the panelists to provide the detailed snakebite cases during non-monsoon months and how they differed and important lessons from each of these cases. So, with that understanding of year-round snakebite prevalence, we move to the next section of our webinar about importance of year-round sufficient stocking of anti-snake venom serum. So I will go to our panelists, and they will provide 1 or 2 minute bites relating to the ASVS year-round stocking practices. That why 10 or 30 vials must be stocked throughout the year. What are the common pitfalls in stocking, and rapid input relating to what one action hospitals must take to avoid ASVS shortage. So I would like to start with Dr. Joy Kumar Chakma for his input on the stocking practice.
Yeah. Thank you, Dr. Falgun, mm, to invite me for these discussions. And just listening from the expert and the treating physicians, yes, definitely snake bite and venomations is not solely a monsoon disease, and there are certain significant number of cases happens to be beyond monsoon or before or after the monsoon periods. And as highlighted by some of the expert, that these non-monsoon cases are more complicated comparing to cases presented during the monsoon. So more attention is required to taking care of the non-monsoon cases. So here we are discussing year-round stocking of ASB and why 30 vials should be stocked. Yes, looking into the situation, and also as already discussed by the previous expert, that a snake bite is treated not only with SB, with supportive treatment, having supportive treatment like atropine, neostigmine, adrenaline to be available always with the health facilities for treating snake bite. I think that maybe they are in the training module that you have developed, so that
Yeah.
every physician who get trained or who go through the module, they should be aware of this fact. And also, like one of the speaker has highlighted, that this training module will make the treating physicians or healthcare worker dealing with the snake bite envenomation from fear to confident, and then timely intervention and treatment. Yes, that's a very great message. Then this every health care worker, especially in the rural and peripheral areas, must have, because as we all are aware that snake bite is a disease of, I mean, socioeconomically backward populations and also populations of the rural. As you all know, still 75% of our country populations are belong to rural, and many of them are agrarians and many other livelihoods that risk them to get snake bite and venomations. Okay. Now coming to stalking, as you all know, snake bite, ASB, anti-snake venom, is very precious for us because there are very limited manufacturers, and the proportion of the cases, as you are aware, in the country doesn't suffice requirement with respect to production capacity or manufacturing capacity of ASB, that, as you all know, and the quantity of the ASB manufactured by different manufacturer. As you know, there are 4 to 6 manufacturer only, including BSB and other private entity and some of the government entity. Significant percentage of them goes outside the country for export, for supply to other countries. And also ASB is required for the treatment of non-human snake bite, like for treatment of domestic animal by veterinary sciences. So ESB is very precious for us with respect to treatment of snake bite. So stocking, yes, that's a critical issue because this precious ASB, if we overstock, so we might be taking away the chances of other people where they require, where there may not be adequate stock. And if we understock, we might be risking the victim of snake bite not getting adequate treatment. So as per our snake bite management guidelines, national guidelines for treatment of snake bite and venomation, we need to give certain number of vials, for example 30 vials to be infused. So looking into the requirement as well as to for a buffer stock, say buffer stock, and also looking into seasonal variability. Yes, year-round stocking of ESB is important, although that may be variation during monsoon and non-monsoon period. As Tutri expert has given data also, nearly 1/3 of the snake bite cases which are more complicated happens to be during the non-monsoon period. Okay.
Yeah.
The other challenges come out to be is the supply chain and logistics. As you know, our country has a very geographic regions, difficult terrain, and there are hilly areas, hard to access areas. For these regions, having sufficient stock for treatment of snake bite is very important because snake bite happens in these areas, and these are the people at risk. So having said that, appropriate implementation of the guideline, national guideline for snake bite management implementation, and also proper training, adequate training to the healthcare staff with respect to strengthening of the health system, not only with respect to infrastructure, physical infrastructure, else also human
Agreed.
infrastructure. Very important.
Agreed, Dr. Chakri.
With
Yeah.
respect to optimal utilization of our previous ESBs. So that's all from my
Agreed,
side.
agreed.
Yeah.
Sure. Thank you for your valuable inputs. I would like to ask Dr. Senthil Kumaran relating to the stalking practices that are observed around his area and at his center.
Sir,
Yeah,
am I audible?
yeah, you are audible.
Sir, we have to make ASV as a non-negligible emergency drug like retinoid. So we have to do minimum stock has to be maintained. So we need to know that it is not that it is a seasonal disease. It is it doesn't occur only in the monsoon. Around the year it is occurring. So we need to be very clear that it is our mindset has to be changed from the seasonal mindset, and the stock should be done before the monsoon, and that leads to dry season also. We can have it, and what we practice in our hospital is we have a buffering. We have at least 40 wells will be stored. So this can be managed. If suppose a patient 3 or 2 patients comes immediately, we can able to manage, because we are in the semi-urban area. So it will be very easy for us to get from the people, and from the dealer we can get it immediately. So we need to be having a buffer, and we need to have a proper system how the hospital has to store the ASV, so that we can come across.
Okay. Thank you for your input relating to the stocking. I would like to ask Dr. Dayal Bandhu Majumdar to quickly provide his input relating to the stocking practices that are seen in West Bengal. Dr. Majumdar. Yes, sir.
Yes, actually, in our state, West Bengal, we have made it mandatory to stock minimum 50 vials of ASV in the minimum bedded hospital, that is at BPHC. There is clear government order that minimum 50 vials of ASV must be present in all the bedded hospitals of West Bengal. Actually, in the medical colleges and large apex hospitals, they stock more than 300 vials of ASV throughout the year. I have presented 2 cases of very recent 2 cases in the BPHCs, where the 11-year boy was admitted. There, they had stocked 90 vial of ASV in the month of February. As on today, they have 90 vials in their stock. And where the group went for treatment for Russell Pepper White, that is in Mangalkot VPHC of Bardwan district, it is 200 kilometers away from Kolkata and 35 kilometers away from Bardwan Medical College. This BPHC is stocking 310 vials of ASB as on today. I had contacted the BMH of that Mangalkot BPHC. They have 310 vials. I know this is not possible for private hospitals like that of Dr. Sadanand Raut. Yet, when the patients come to a small hospital like a BPHC, they must be given adequate amount of ASV throughout the year. So we have clear instruction for the bedded hospitals to stock minimum 50 vials of ASV, and our district level officers, that is Deputy CMH2, they are very much vigilant about this stock of ASV in the BPHCs. Thank you.
Thank you, Dr. Majumdar, for providing the apt feedback relating to the stocking practices prevalent in the West Bengal region. And next, I would like to ask Dr. Uttam Ingole that what stocking practices are seen around his area, that he is representing the Maharashtra region, rural Maharashtra region. So that would be interesting to know.
As I have already told you that, and also Dr. Raut told that non-monsoon period, there are almost 25 to 28% of patients that come, and for that the anti-snake venom that is required at your stock, it should be at least 100 vials, because Russell Swiper, he needs almost 30, 40 to 50 vials, and immediately second patient comes. At that time, to supply from Bharat Serum, it is very difficult to purchase from our district level. Patients of snake bite, they will come to you only because you are treating at the center or the rural areas. Other doctors, they are not treating, and even though government doctors they are not properly treating. In government hospital, there are anti-snake venom, but they are not they are using. And in other doctors who are practicing in the same place, they are not also they are keeping medical anti-snake venom vials in their medical stores. That's
Yeah.
why
So at your center,
doctors should be
usually 100
prepared
vials are.
for the struggles. I am having at present 420 vials, and in non-monsoon
Okay.
period I have used 305 vials. It means that in 1 year I have used 1000 and almost 150. It means that 1200 vials, almost 1/5 of vials that are required in non-monsoon period. Thank you.
Thank you, Dr. Ingole, for providing the data-based input relating to the year-round stocking practices prevalent in your region. And at BSV, we are committed to provide the required vials to each and every healthcare providers throughout the India. With that message, I would like to move to our next section, ensuring patient access to snakebite centers. And I would like to have a quick bite relate from our four panelists on this, relating to the what best medium for patients to find emergency care centers for snakebite. And we are working at BSV to develop 100 snakebite treating center in highly prone regions and make them easily searchable online. So how beneficial could this be for patient access and timely referral? So I would like to start with Dr. Joy Kumar Chakma to provide his quick input in 1 minute. Dr. Joy Kumar, your mic is on mute.
Oh, sorry. Thank you. Am I audible now?
Yeah, you're audible now.
Yeah. Thank you very much. Yes, timely treatment and available of treatment is very important with respect to snake bite. As you all know, snake bite is a medical emergency which is same like of any cardiac event or neurological event like a stroke. It is a very golden window. Yes. So that's why the patient reaches to the nearest health facility where they can get at least primary dose of ESB or primary treatment, and then can be referred to hair center is very important. I will just share you experiences from ICMR studies that you all might be knowing, because Dr. Raut is part of that team, and also Dr. Umesh is there. Yes, we have done a pilot study with respect to strengthening of the health system, with respect to capacity building of the healthcare staff, and also to do streamline referral system. Okay, in Maharashtra by Dr. Rahul Gajbe and other team. So, with respect to capacity building, increasing the capacity of the healthcare provider for timely treatment and making the health facility accessible to the victim significantly reduces the morbidity and mortality. And also where although the final data analysis is not there with ICMR, where we have conducted a national level study to estimate the burden of snakebite with respect to prevalence, incidence, morbidity, mortality, health-seeking behavior, and also economic fallout with respect to snakebite, where preliminary data analysis also indicate that community awareness and timely referral for patient reaching to health facility where the snake bite treatment or management facility is available, definitely very important and significantly reduce the morbidity and mortality of the cases, and also making the community aware that ASB is the only treatment which can cure snake bite cases, and not to primarily seek treatment from the traditional healer where there is a faith of the people living in the rural areas, they are they approach traditional healer. That could be reason being sometimes the health facility is not that far, and the traditional healer are nearest to them, and they have good rapport with them. So community engagement is also very much important. That's all from my side.
Thank you, Dr. Joy Kumar, for providing your valuable inputs. I would ask Dr. Omesh Kumar Bharti to provide his input relating to the BSV's initiative on developing 100 snakebite treating center and making them easily searchable. Dr. Bharti.
Thank you. We are coming to the topic. Let me explain a policy level view of ASB. I talked to CRI Kasoli. Why you're not producing ASB, in a sufficient numbers? So because ASB can stand for the 2 to 3 years lifespan. So they said we need advance orders because of the horses are to be immunized and ASB to be produced. So since Dr. Joy Chakma is here, some instruction should go that based on previous ASB use, there should be advanced ASB order to the companies. So there is a big gap between the utilization requirement and the orders. So this is what I want to say is that advance orders should be a priority and should already be there in the PIP or in the expenditure of the government, especially for ASB, ARB, and anti-rabies serum. So that is one thing that I would like to share as a policymaker. And regarding year-round ASB, I think due to false belief that only monsoons bring the snake bite, I think that's what I would like to congratulate this today's seminar. It's unique in the sense because they are talking about beyond the monsoon seasons, because now especially Russell Viper is, I have seen in my Himachal Pradesh that Russell Viper, just in this Sunday, last Sunday, we rescued one Russell Viper who was sunbathing outside the school. So any misfortune, any miss something may have happened. So I think this is a good initiative, and at least we should be prepared to keep at least 30 whatever load of our snake bite is, we should at least think of 30% people coming in the non-monsoon period, and accordingly vials should be stored, and orders should be given in advance for the next year, this year, so that manufacturers can be in advance they can produce the antivenom. Thank you.
Thank you, Dr. Bharti, for your inputs. I would like to ask Dr. Sadanand Raut relating to patient accessibility to centers, and if we make the centers searchable online, then how much can it help the patients? Dr. Raut. Dr. Raut, you there? I think we can ask Dr. Ganpati relating to this thing of based medium patients find their centers and how we can improve the reachability of patients to snakebite treating centers. I think, sir, you are not audible. No, not yet. No, sir, you are not yet audible. I think let the system to check. Dr. Raut is there. Dr. Raut, can you provide your input relating to the patient access to centers and how we can improve the searchability of the centers? Dr. Raut? I think there are some network issues. So with this insight from two of our panelists, we can seek the additional inputs later on. but we would like
Yeah.
to.
If Dr. Falgun, if you allow me, I can give one or two input. Right
Even
now
I can
going
say
on?
something.
Yeah,
Yeah, sure, sure.
yeah, yeah.
Uh,
As you know, Dr. Falgun, the government of India has launched the National Action Plan for Prevention and Control of Snake Bites. In that line, as Dr. Umesh already, which highlighted that ASB should be procured in advance and capacity for manufacturing should be enhanced. Yeah, in that line, they are taking some actions with respect to increasing production, and also government of India has allocated fund to the state government under NHM with respect to with respect to investment on infrastructure as well as logistic or ASB, and also in capacity building. And it is Dr. Umesh itself, I think, aware of that. And with respect to how we can locate or how the victim can access the nearest health facility. So I think there are in certain districts as a pilot program, the government of India in collaboration with the state government launched some helpline 24/7 when snake bite happened. If they call and that help through that helpline, they will guide the victim to his nearest health facility. And also they are what doing like there are for certain emergencies dedicated ambulance, so that may be also route into transport snake bite victim also. That's all. Thank you.
yeah,
Yeah,
thank you, Dr.
yeah.
Joykumar, for providing government initiative relating to SEM. Dr. Raut, you are there?
Yes, yes.
Yeah, so we'd like to have your bite relating to the patient accessibility to the centers, and if BSV works on developing 100 snakebite treating center in highly prone region and make them easily searchable online, how beneficial this can be for patients.
This is very good idea actually to develop a dedicated snake bite management centers, and this will definitely help to reduce the mortality and morbidity also. There should be a referral calls from the local doctors. There may be a medical officer or a private doctor. He should call to the referring center. 10 at ambulances should be more made more stronger, at least in Maharashtra, along with the availability of ASV in the ambulance. Then sure, there should be a Google search for the snakebite hospital near me. So people
Hmm.
should easily identify that, and local chemists or ASHA workers and A&M referrals, they will be also useful. The treating hospital numbers, snakebite treating hospital numbers should be given in all the localities to the local leaders, and their WhatsApp groups should be made. And of course, word of mouth in the village that these hospitals are treating snake bite patients. Just like in our area, we had seen that from 100 kilometers, when there is a snake bite, first name comes of our hospital. So that is word of mouth in each village. That will also help to reach the patients to the nearest hospital as early as possible. And this will be made. This center should be made in the most uh, snake bite prone areas in other states also. So the 5 6 steps should be selected initially, and then this center should be started. That will be definitely beneficial.
Yeah, thank you, Dr. Raut, for providing the valuable insight, and thank you all the panelists. With this, we are
Dr.
moving to the
Farun,
final section. Yeah, yeah,
Dr. Farun, let me share just one insight. As Dr. Jayakumar Chakla is present here,
sure,
beside
sir. In
all
1 minute,
these,
please.
hello,
Yeah, yeah. Just a quick point.
beside all these suggestions, I would like to bring attention of Dr. Jayakumar Chakma that one VRT model, Venom Response Team model, is working very nicely at Sibsagar district of Assam. Dr. Surajit Giri had structured this, and they have made the area zero snake bite death. It is VRT model. What is a VRT model? Just like ASA workers, some volunteers will be given incentive for bringing the snakebite victims to the treating hospitals. They are designated as VAT, Venom Response Team. It is working very beautifully at Sibsagar district of Assam. I have given proposal to my government officials year back 2022, but they are not accepting this. I think this should be done centrally. Just like ASA workers are given incentives for bringing mothers to the institutions for institutional delivery, the snakebite patients should also be given incentive to these VRTs for bringing them to the treating hospitals. And very recently, Dr. Dilip Som, one NRI engineer now is established at California. He is a Bengali engineer. He has developed an app for snakebite, just like this, locating, treating hospitals and like this. His Google search based app is showing some false hospitals. All the non-bedded hospitals are also shown by this Google search.
Yeah.
That will mislead
Agreed.
the people.
Agreed,
Thank
agreed.
you.
That's a very responsible thing to
Dr.
do.
Dayal, let
And
me
with this-
compliment what you are, Dr. Dayal, what you are saying. I built in the ASHA incentive in the PIP of NHM that was struck down recently in recent meeting by the government of India, saying that if you start giving an incentive to snake bite in Himachal, we have to replicate it throughout the country. So I think Dr. Chakma should take a call because the PIP NHM Government of India was rejected this proposal from Himachal Pradesh.
Yeah,
Thank-
sure, sir. I will convey this message and carry forward because I am also working as a stakeholder with NCDC, National Center for Disease Control, which working on snake bite management and control, and also to launch and snake bite management and control program from the national level. So I'll definitely discuss, and I know, yeah, Dr. Dayal sir, the Surajit Giri's model and about zero snake bite and what they are doing, and we have discussed also with Surajit Giri. But only thing is, because as you all know, replicating this model become difficult because our country at the present moment, even and in most of the rural healthcare infrastructure like PSCs, CSCs, they do not meet the IPSS standard, Indian Public Health Standard, all with respect to healthcare worker, doctor, nurses, as well as facility infrastructure. So, developing or replicating the model what Surajit Giri has definitely shown is possible if the government take political will as well as wish to put money, so that rather than replicating a separate snake bite treatment center, we can strengthen the CSC, at least if not PSC, CSC level healthcare worker with putting some additional health resource for dealing with snake bite. So definitely, whenever I get the chance with the policy team with NCDC, I will convey this message to them. And also, as you might be knowing, Dr. Menon from Kerala, they have in state-wise launched Zero Snake Bite initiative also, that ICMR is also part as a stakeholder. We'll try to find out from their initiative what other things that can be implemented at state level, or even from with the collaboration with center looking into that. Thank you, sir.
Yeah. Yeah, thank you all the panelists for the fruitful discussion on patient access to snakebite treatment centers. With that, we are moving to the final section of today's webinar, and a new product is on the way. So I would like to ask Dr. Krupa Morzello to provide the valuable inputs about the upcoming new product. Dr. Krupa.
Yeah, thank you, Dr. Falgun. So this is something which is very, very exciting from BSV, and it is, one of the first time in India though there have been many international companies for the other snake anti-venom seras which are available, but this is the first time in India which is available. It is a totally WHO recommended product, and what we will be launching very shortly in around 1 or 2 months is what we are calling as ASVS 50. Now, the biggest benefit of this whole product is that we will ensure, that patients are getting a complete therapeutic dose, because sometimes they do not get the complete effective therapeutic dose as early as possible. So, what this is going to be is a single effective product. The volume of the product is 50 ml, and we are be selling it in a lyophilized form. There will be a WFI which is provided along with it, and BSV of course has a reputation of our product having a very short dissolution time. So the time of dissolving this product in the WFI is going to be less than 10 minutes. And what it will help is in shortening the time in giving this ASVS to patients, because it will give you a complete, pack size of what you would normally have of 5 vials. And this is going to be very, very beneficial to doctors and to patients to ensure that, the product can be given on time. So this is something we are very excited about. We have completed all studies with the product. It is right now at the stage of going to CDL Kasoli for testing. And we are sure, we are still going to keep up with the same product quality as earlier. And this is something we are really looking forward to. So thank you very much all the doctors for all your support over the so many years of BSV supplying ASVS, and we really look forward to getting feedback from you once this product is launched. Thank you, and thank you, Dr. Falgun.
Yeah, thank
Ma'am,
you, Dr. Kripa, for this valuable insights about the upcoming
even
new
1 minute,
product.
just before
Yeah,
concluding. Actually, when I was in WHO, I was given a suggestion to have 100 ml, because delay in reconstitution. Every time when we are reconstitution, there is a lot of pyrogens entering into it, making the patient shivering. So with a single insectant, with just like with the filter, then it will be sufficient for the patient to overcome the allergic reaction following ASV. So you can even consider ASV 100 in future.
Yes, sir. We will do that, sir. But right now, we just wanted to stay with the 50, and we are still keeping our 10 ml product also. So, if something like 7 vials or 8 vials have to be given to patients, you will have access to both the 50 ml and the 10 ml. So, we will not be discontinuing our 10 ml product. And yes, we will take your opinion into consideration of also launching 100 ml vials. Thank you for the feedback, sir.
thank you, Dr.
Yeah,
Senthil Kumar.
I will, if you allow, I will just try to get quick clarification, 1 or 2 point, Dr. Falgun.
Sure.
Yeah, Dr. Kripa, I
Yes, sir.
think this is the same ASB that you are only increasing the quantity, right?
Yes, yes, sir.
Yeah,
Yes.
yeah,
So it is like
yeah.
5 bottles into one bottle.
One bottle, correct. And
Yes, sir.
the other expert told you can also make hold the dose or recommended dose of 10 bottle into one
Yes, sir.
dose. Okay.
Yes, sir.
Yeah, that's fine. Yeah. That will definitely, be helpful, as I understand. But later on, we'll know when you will be truly implement it, because keeping 10 vials, storing, transport also become, sometimes difficult, rather than comparing like you are doing it 50 ml. So 5 vials together.
Yes.
Since ASB is infused very slowly, as there are my clinician counterpart is there, they are more expert than this. Since ASB is infused slowly, so slow infusion of that either 50 ml or 100 ml should not make any difference if we take care of the issue of enough getting allergic or anaphylactic reactions. With pre-treatment, as already pointed out, that adrenaline, atropine, and other things are must along with ASB. So
Yes.
definitely, yes, it may ease out in treating snake bite. Yeah.
Dr.
Thank you, sir.
Chakma,
No,
I think
my question, my
what
question,
the ASB 50 will do, it will reduce the reconstruction time only. When
Sure, sir.
ASBs are reconstructed, it takes more than 20 minutes to reconstruct 10 vials. If there is only one nursing staff and one doctor, it kills time. This ASB 50, only 2 vials will be reconstructed within 2 minutes. And whenever we give ASB, not only slowly, it's not slowly. Actually, there is no difference between 20 minutes and 120 minutes. There are multiple publications. If you give within 20 minutes, it will make the same reaction. If you give it over 120 minutes, it will give same reaction. This ASB 50, it will also be infused in the NS bottle, not directly. It will be mixed with NS bottle. Is it?
Yeah, definitely.
Am I clear, Dr. Kripa?
Yes, yes, sir. Yes, sir.
Yeah, thank you, Dr. Majumdar, for providing your input.
Thank you.
Vighnahar,
Yes,
I'm just
what
differing with you.
Dr. Majumdar has told, it is
can I
clearly
ask one
right.
question? Would this ASB 50 would be
Yes, Dr. Bharti.
ASB 50 would be crippling acid fractionation or what?
Dr.
Sorry?
Chakma was telling something. Dr. Chakma?
No, I think Dr.
No,
Bharti is saying
what-
something. Dr. Raut?
Yeah, let Dr. Bharti, yeah. Dr. Bharti, please.
Yeah, Dr. Bharti. Yeah, please.
Yeah, I'm saying would this ASB would be crippling fractionation the same fractionation that is continuing?
Sir, your voice is a bit muffled. Can you speak loudly, Dr. Bharti?
Ma'am, he is asking whether it is
Would this
same.
ASB 50 would this
Yeah.
ASB 50 would be
Yes.
crippling acid fractionation as recommended by WHO,
Yes,
or the same
yes,
process
sir.
as being carried out?
It's the same product, but only what we are doing is we are clubbing 5 vials into one bottle. So it becomes much easier reconstituting it, and it is much easier for the doctor rather than earlier you would have to open 5 bottles, reconstitute each bottle with the WFI, open the WFI. So even the WFI pack will be a very convenient pack, with which can be reconstituted straight off the 50 ml bottle, and then so
why don't you shift
required.
to crippling acid fractionation?
Sir, the
Why don't you shift to
fractionation
crippling
has
acid? No, that's why.
caprylic acid, no, sir? Yes, sir. We are already using caprylic acid fractionation. We are already doing that, sir. And we are also doing column chromatography. So there is very low aggregates in our product, sir. It is less than 1%, what is there currently.
Then why reaction rate is so high?
Sir, maybe from our clinical team, somebody will be able to answer that. Dr. Falgun, or if Dr. Mangesh is there.
Yeah, we can
Actually, the
check
reaction
and
is
get
not
back to-
because of the ASV. It is because of the way we are administering. If you use a clean hand with a clean water reconstitution, we have not even seen any reaction at all. We are treating more than 400 cases per year, and our incidence of anaphylaxis is less than 0.1%. Unless you use proper reconstitution technique, no reaction comes. We are talking more about the reconstitution. I'm actually happy that, but I'm happy that by using AS250, the pyrogenic reaction will be less. We have tried with the BSV, we have tried with various other preparations of ASV, and we have seen that the quality of BSV is better, and the reaction occurs is just like a pyrogenic reaction. If you observe properly, only with the clean hand we can reduce it. not exactly with the anaphylaxis reaction.
Yeah, thank you, Dr. Senthil
But
Kumaran, for
sir,
providing
studies
the.
across the country, studies across the country say 20% anaphylaxis.
Sir, we
Yeah,
have seen only 1 or 2 cases of anaphylaxis. I am taking care of almost 22 countries in WHO panel. We have trained the VHNs, we have trained with the nurses with the clean hand technique. After that, the incidence of anaphylaxis has grossly dropped. You can verify the literature.
sure. Thank you, all the panelists, for the really enthusiastic discussion around the new product. And with that, I would like to mention the key takeaways and action points from this webinar. That with this webinar, we have the clear understanding of that the snake bite is a year-round emergency and not just limited to the monsoon season, reinforcing the need for continuous preparedness. From non-monsoon snakebite cases, we gain insight about the emerging trend and risk pattern, and all year preparedness is required that we have come to conclusion. Consensus on strengthening year-round ASVS stocking about 10 to 100 to 50 vials depending on the regional practices, improving supply chain predictability and reducing stockout risk, and actionable steps to improve patient access, including better referral pathways and improving visibility and searchability of more centers throughout the country. And finally, we look forward to organizing more such expert panel webinars, creating momentum for sustained improvement in snakebite management. So, with this, I extend my heartfelt thanks to all the esteemed panelists who are one of the leading snakebite treating experts of the country for sharing their deep insights and expertise, and to every participant for investing your valuable time with us today. We are almost more than 38 minutes to our scheduled time, but still we are having a really insightful discussion. So thank you all for present to this webinar. Thank you.
Thank you.
Thank you.
Thank you.